to give space to a person's story and all those things that sit below water that you speak of. That takes you sitting in front of a person and just, I always say, shut your mouth and listen of what they've been going through and all the things that you spoke of that your pain groups talk about, and that jives with what the research is saying. Everybody, welcome back to another episode. This week's episode a little bit different. I had Pete Moore, my friend from the Pain Toolkit. He does a monthly Q&A in his academy. They do some great work over there, so we'll link his stuff in our show notes. But we're going to do a little bit of a shared podcast where Pete's going to share it with his group. We're going to share it with you all. These are basically questions from his audience, from the folks that are in the Pain Toolkit Academy, oftentimes lived experiencers, but I do believe they have some clinicians in that group as well. So they posed some questions to me, and we talked a lot about things that are really all about really our mission and vision at Modern Pain Care, and also a shared vision and mission of what Pete's trying to do in his Pain Toolkit group. So that obviously gets to really rethinking pain, getting beyond the tissues where we're treating humans and not scans. We talk about listening as an intervention, where really we just need to shut up and listen to our patients to let their story have a stage so we can make sense of their story with them. We also talked about how sensitization flourishes when life gets small and how we as clinicians can help widen life again through helping share that expertise with the patient in front of us. And we also talked about this hero clinician role that we need to swap for a shared expertise where the patient is the greatest expert on their unique pain experience. I think you're going to like the episode. I'd love to hear your comments. And if you're not subscribed, I'd love if you could subscribe to the podcast so we can get this message reaching more people. Enjoy the episode.
This is the Modern Pain Podcast with Mark Kargela.
Hi everyone, it's Pete here for the Pain Toolkit. And listen, look at this. I'm flipping the tables. I'm daring to flip the tables with Mark. Hi Mark, how you doing?
I'm doing great, Pete. Always good to talk with you.
Yeah, mate, likewise, man. Hey, listen, I'm flipping the tables a little bit because Mark's been doing a load of recordings with people I know in the pain management world and people I don't know, and I find them super interesting. If you haven't seen them, go and track down Mark on his. I think I've taken it there on YouTube.
Yep, Modern Pain Podcast on YouTube is where we're at.
So whether you're a person living with pain or a healthcare professional, then go check out Mark's interviews that he's been doing, because they're about to increase your skills, etc. But anyway, I reached out to Mark a couple of weeks ago because we, over at the Pain Toolkit, myself, Keith Meldrum and Dave Oxley, we do the Pain Toolkit Q&A. I thought it'd be fun to flip the table. Let's get cracking on the questions, and I've had some interesting ones come through. First one's from a guy called George from the UK, and he asked, it's a rethinking pain, and he says, you emphasise the importance of rethinking pain. But can you explain what does that actually mean to you and how it influences your approach to treating patients?
Yeah, I think it goes back to how I was taught pain. And I think in school, in physio school, it was like we got to the gate theory, but was still very peripherally driven around the tissues were really the determinant of what pain you felt. And there's some truth to that, right? There are situations where you break a bone and that message pretty much is very clear with the pain experience that you feel is very almost proportional often, although you'll hear stories of veterans in battle who've had amputated limbs and carried them off the battlefield and with minimal pain because there's so much adrenaline and other competing things going on. So even then situations pain isn't as neat and tidy as we'd think it was. So I think for me, rethinking pain means understanding pain is so much more than the tissues. And I think that was evidence in my career of failing with people when I only looked tissue deep at what was going on with them. I just had 10, 20, sometimes 30% of my practice who weren't responding when I only focused on their tissues. And I would have a lot of difficult emotions coming in my treatment room. I'd have difficult life experiences coming in my treatment room and different things that I didn't know how to process and understand much because I was like, well, let's just talk about your tissues because that's what I'm here to figure out and fix with you. People were like, that whole body is a machine narrative that permeates healthcare still to this day, where people are like these mechanical beings that are just needing to be fixed. And that's how I looked at pain for a while. And then it was a couple of instances where I was ready to quit because I just felt like I'm just not good at physio. I can't, these 10, 20, 30% of people I can't figure them out. I read Lewis Gifford's work, who's a pioneering physio over there in the UK, who unfortunately passed way too soon from cancer. But he was probably one of the more turning point situations where I realized, along with having some pain science introductions and just hearing stories of people, it was a big aha moment for me to realize that, yes, if I just strictly focused on the tissues with people, I was doing them a disservice, because we know pain is a sensory and emotional experience, as IASP defines it, our big body of pain knowledge across the world, that people's experience and distress around their pain and how it interacts with our stress systems, our autonomic systems, our hormonal systems, our HPA-axis, I'm not going to get too nerdy into the science, creates an environment where pain can flourish, where sensitization of the body and dysregulation of your GI, your migraines, and all these different things coalesce to create a very complex experience. And it takes much more than an interrogation of tissues to understand that. You have to understand the unique human in front of you, their unique story, their unique experience, the unique things that have them distressed and worried about what they're losing in their life and how life has gotten small with them. So I guess that's the big picture way of how I look at rethinking pain, as far as rethinking it more broadly from a whole person perspective, not just what their x-ray and their MRI looks like.
When I'm talking to, whether I'm coaching or just touching the healthcare professionals or patients in general, really, after 3 months, pain, I call it, we become very complicated people, because after 3 months, when it's like pain's become persistent, or over there, I know you may say chronic over there, especially when I talk to patients, like when you say, well, what are your problems? They never mention pain. They start talking about all the other stuff, sleep problems, money worries, and just overthinking and stuff like that. And that actually supersedes the pain itself. So after 3 months, like, we've become super complicated. When I always say that we've got to perhaps deal with those factors first before you can. I think managing the pain will slot in. I remember being on our pain management program back in '96, that when they went round the room, they was talking about, people very rarely talked about their pain. They talked about how they can't sleep, they lost their mobility, their confidence, etc., lost their job, having problems with their family and whatnot. So yeah, it's had a thing what I like about your work is that you've had a bit of as you say, like a little bit of a rethink, really, that I was dealing with all that other stuff is really important. But I think, I suppose, a little bit of an add-on question to that is, how do we get your colleagues in? They're so anchored into the medical model. It's like, oh, you're trying to get them. I don't know if it's like when I say to them, what about doing? They say, well, we ain't got time.
Yeah.
That's all that mumbo jumbo stuff, like. But the thing is, unless you deal with that stuff, I always liken it to that one of the slides I use, that the iceberg, where you've got pain at the top of the iceberg, and then below you see a third of the iceberg, and then underneath the waterline, the extra 2/3 of it. And pain's a little bit like that. It's at the top, but all the other stuff, bigger stuff, is below the waterline. And what I found over the years is that if you deal with that stuff below the waterline, then that will wind the pain down. Like, but what would you say to your colleagues who are a bit stuck still and not rethinking pain?
That is a question I toil with every day, of how to reach them, because I think there's a couple of things at play there. I think there's systemic barriers that our healthcare systems don't give us the time, unfortunately, and space to give space to a person's story, and all those things that sit below water that you speak of. That takes you sitting in front of a person and just, I always say, shut your mouth and listen of what they've been going through, and all the things that you spoke of that your pain groups talk about. And that jives with what the research is saying. Like, Camper did a study on what people in chronic pain wanted out of an encounter, and 60% of them wanted to talk about issues in their life. It wasn't just, what their x-ray looked like. Some of that was, of course, and that's fine. So I think, again, there's systemic barriers where we make it hard to give people's story the time and stage it deserves. And it requires, if you're going to really help somebody who's dealing with some complex pain situations. And then I do think there's some clinician barriers as well, and I've just recently had these discussions. I think clinicians feel the need to feel like they belong, and that they have the knowledge and expertise to the point they want to be controlling the expert on this pedestal, where we really try to train clinicians that you need to understand that there is a shared expertise in the room, that you are on the same level as the patient. You're both humans, right? And the person who has the most expertise on a pain experience is the person experiencing the pain, right? And what uniquely it feels like with them, what things in their life affect it, how it's changed their life, what struggles it's brought about in their life as a result of that. And then that gives us the space to then help patients put pieces together. But how do we get clinicians to change? Systemic change is tough. Part of why I do the podcast and social media content, I'm not a huge fan of social media on its own, but it's a vehicle to get this message across, because I really try to put things out there, because I know if people are honest with themselves, clinicians, they know there's these people in their practice that require more than what our systems are allowing. And we need to give those clinicians tools to be able to get a story, to take a person's story in and validate it and help people make sense of that story and how it relates to their pain. So I try to put content out there that helps clinicians question what they're doing, because I was one of those clinicians who just felt like I needed more expertise so I could dictate and fix these people in pain. It was a me problem, but it wasn't more techniques. It was an approach of being able to suspend my need to be the expert in the room and really understand the true expert in the room is the person with the pain, not the person. And my expertise needs to fit in with that person, where I can definitely throw physio and neuroscience expertise and things in there. But if it doesn't resonate with how it's going to move somebody back towards their life, then it's not as much meaningful information. I think that switch is trying to help push clinicians to make that switch. It's not easy. I'd love to say I have all the answers for that, but it's part of why we do our coursework too. And I just got off a call with one of our students who's really feeling like they're making some big strides in their practice. So I think we do it at a grassroots level to help clinicians start making the change. And then we highlight those changes with sharing the stories of our clinicians who feel like their practice is much more meaningful, much more impactful when they take this type of approach.
Yeah, it's like I was talking to Keith Meldrum about this and other self-managers, and it's like, I was stuck like, but it's like where it's like the healthcare professional gets stuck and the patient's stuck, and they were missing each other sort of along the way. So a bit bonkers. But I think it's got to start. Well, we've got to do the work, but also I think healthcare. I think that the starting point is with the healthcare professionals, because we're the patients go and see for a little bit of guidance. So I think it's got to start from there. Okay, number 2. So we've got Gwen from Australia, and this is quite an interesting one. Gwen asked, the title of the question is Humanity in Pain Care. You advocate for bringing humanity back into pain care, but what are some of the specific practices or philosophies you implement in your work to ensure the patient feels understood and supported through their treatment journey or management journey?
It piggybacks off of what we just spoke about, but I think it's respecting the expertise of that patient and the humanity of their experience, right? I think too often we get caught in the biomedical components of their experience, where their lab tests and their x-rays and all these things, which can have a place. I'm not here to say that those things aren't important, but the human story that revolves around pain is often what drives it to become persistent. It's the loss. It's the not able to do the things that are meaningful to them. It's their life shrinking around their pain. Yet medicine still gets so stuck on wanting to interrogate tissues and blame everything. And nobody just listens to a patient. It seems easy, but I can't tell you how many people I talk to that navigated a healthcare system where they're dismissed. The doctor wants to get to the next appointment. And I don't want to come across that. I realize that there's physicians who have all the best intentions in the world. I was probably operated in some of these settings in my past where they just simply don't have the resources to give the appropriate amount of time and things. And they're under pressure. They're burning out. They have compassion fatigue. There's a lot of issues that create maybe healthcare interactions where it's not the ideal situation for the humanity of the experience to come out. So I think understanding, that's why I love having interviews with people like you and Gilletta and Keith and Trevor and Tom and others who are people that have been through it. Because I think it's important for us to not lose sight of that human story that accompanies pain. And it's one that, as I talk to you all who are lived experiencers, it's one that I'm dedicated to keeping front and center when we have events, when we have conferences, when we have things, because honestly, I've learned more from that. I definitely have learned from continuing education within my profession, but honestly, I've learned more from talking with people who've navigated their journey of how to better help them than what next technical skill I'm going to learn in my craft. So I think I tell my students, be a good human. If that's the way you approach your care, you're going to probably do well. And what does that mean? This looks like it's been hard for you. I'm so sorry you've been through this situation. How's this impacting your life? Pretend it's your mother or your aunt. And it's not that we don't genuinely care, but I think we have this, I'm the clinician and you're the patient. No, we're two humans in the same room. I have my own struggles as a human. I've had pain and different things. I'm not there to compare to patients' pain, because obviously oftentimes they've navigated a much, much more difficult journey. But I think if you can take that approach of we're two humans trying to come together to make an encounter that moves them towards something that's meaningful for them. And I think too often we have a clinician agenda versus a patient person in front of us agenda that can get us stuck and struggling.
To me, it's also of healthcare professionals that we got 2 of them. And one of those sort of gives the game right, really. And I would say, learn to listen, and listen to learn. At the end of the day, we do I think what happens is we, like as I mentioned earlier in the other question, if we get patients get stuck in a medical model, and we don't want to be in it. We want to get on with our life, sort of thing. But we're so anchored into it, and we need to. So at the end of the day, we're the ones that have got to be doing all the work, most of the work, really. So we're looking to the healthcare professional for it. But it's a little bit. I keep going back to learning to drive. Do you drive? Do you drive still? Do you drive?
Certainly.
Yeah. So did you take driving lessons?
I did have to take some lessons with.
Yeah. Are you still taking them now?
I am
Or
not.
so so the thing is, when people take learning to drive sort of scenario, they get up to a required standard, and then off we go. But when you was learning, you was in the driving seat, driving, and the instructor beside you, he or she was giving you the guidance and information on how to go forwards or backwards and turning left and turning right, and you got up to a required standard, you passed the test, and push off you went.
Mhm.
But and that's it. And I will say it's not a relationship till death do you part. But as long as we've got that information, that self-management information, we can get back on course as well. Like that's my old boss in when I worked in the NHS, so Jane Thompson used to remind me, we will learn more from our mistakes than we do our successes. Like
100%.
we've got Harrison from Canada. How do you balance your responsibilities? What role do you believe education plays in helping patients and healthcare professionals understand and manage pain more effectively?
I think education is huge. I think another reason we produce a lot of the episodes where patient stories are there is to help patients. I find it more powerful for patients to hear it from people that have walked in their shoes. I think it's the
Mm,
most powerful learning experience that can happen for some patients. And often that comes with those people who've experienced it and are lived experiencers reflecting their understandings of pain and different things. So help and educate patients. I think my approach to educating patients is a little bit more of an invitation, not just I'm going to slam the patient with information whether they want it or not. I think I try to be a little bit more selective with
yeah,
where the person's at, what they're ready to hear, what kind of things are in their way that might benefit from maybe some education that might help them consider a different perspective and then help them work themselves through that perspective. But as far as education of students and fellow clinicians, because we do post-professional education and I work with students in the clinic. So my favorite thing, today after I'm done with you, I'll get ready to go to work. And then I have two students at our university who are with me full time and they are working with my caseload and I'm helping them start to learn these skills. And I practice a bit differently than I practiced when I was early in my career, where I was much more driving. Like you said, I was the driver instructor who was not even letting the student drive. I was just driving, and this is how you drive, student. And I was just taking the wheel and driving and
yeah,
not letting them get the experience, right? I think my care is much more, because I like your analogy, is much more in that guide as the driving teacher, where the student or the patient is behind the wheel. I just try to help them find what destination is going to be worthwhile for them, to move them in a direction of life that's meaningful for them, not for
yeah,
me. And then
yeah,
we can find, well, what's the roadblocks, what's the detours we have to take, or what's the different things along that path that get them
yeah,
to those, because every human has their own unique challenges and unique parts of their story that make their travel or their journey on that road to be different. So I think having those skills, I wish I had somebody who helped me, because I spent years trying to chase clinicians who were the people who were just, it was something in my hands. I didn't have senses to feel what's in their tissues that was keeping this pain persistent. And that almost had me quit the profession twice, because it's
no,
a failed pursuit. You're not going to find it in the tissues. There's information you can find in the tissues. Don't get me wrong. Tissue-based interventions can have their place as long as they're positioned as, like, at most a supporting cast member for the real work of getting people back in the driver's seat of their lives and getting back to the things that are important to them. So a roundabout thing, but I think education to help students be the driving teacher and patients be the driver. I think that's where the education needs to go, is and
yeah.
getting skills to make sure that's the way we drive pain care.
I talk to Keith Meldrum quite a bit. We have a chat most weeks at the weekend. But funny enough, we were talking about this last weekend about education. Education seems to be the key, and and good education sort of
Hmm.
thing, like a tick box thing. But people who receive the right education and also healthcare professionals. There's only they're both everybody's a winner. And I think you mentioned like healthcare professionals perhaps get a bit burnout, a bit disenchanted with it because of they don't feel they're making a difference. But when they see when they're coming from a coaching point of view, or driving instructor point of view, they see people getting on. It puts it's job satisfaction as well, really. So, yeah, it's maybe tough, and we are tough cookies. I know doubt about that because I find talking to people like me really tough as well. Like, and I get frustrated. But the thing is, it's if they get good education, good guidance, etc. There's both the patient and the healthcare professional. We're both winners. Like, I'll give you a heads up. I used to be a driving instructor, so that's why I come out with a lot of. Yeah, back in the day, that was when I had hair actually, and yeah, I started off teaching people to drive. Then I became a staff instructor and teaching people to become instructors and whatnot. So I've ended up with all these sort of scenarios, like.
Yeah.
But great stuff. Thanks for that. One for someone called Charles. Charles, they ask about the modern pain podcast. As a host of the modern pain podcast, what are some of the key topics or expert insights you have uncovered that challenge traditional views on pain management?
Yeah, I think to just reiterate, I think the patient expertise component is one that I don't think has enough stage in conferences, in continuing education courses, in situations where professionals are getting together and discussing, well, these are the things patients should be doing. And there's not a patient within a square mile of that discussion. So to me, I think that voice needs to be front and center when we're having these discussions. If it's going to be shared expertise, we should embody it by how we have these discussions. And there's been positive movement, right? Keith Meldrum's doing amazing stuff. Gillette Belt and yourself are involved with discussions with professional knowledge and are being included in discussions, which I think is a positive first step. As far as other topics, I think just trying to bring out the human component of pain, because I just think that's the big missing piece, that the humanity piece, and there's research to support where we translate life experience and this massively distressing scenario when your life's shrinking around pain and you're losing some things that are so vitally important to you and feeling lost, feeling small, feeling just where life's got us on the sidelines. I think when we can help translate that experience, so this is not just your life experience, this translates into your biology, right? This is when you're in perpetual stress or you're really dealing with understandable depression, anxiety, and all the normal emotions that humans experience when they're going through such a distressing experience, that has a significant impact on your biology and how your physiology. I usually give the analogy of the haunted house versus the beach at sunset. I put patients in a scenario where, how does your body behave? Same body. Let's drop you in a haunted house. Let's talk about, what does your blood pressure look like? What does your tension look like? What is your heart rate looking like?
Yeah.
And all those things. And then you can talk about the beach at sunset or the most serene environment. Let's look at the same body, put it in that situation. I'll often share, like a lot of patients I work with chronic pain deal with IBS, irritable bowel stuff. They have dysregulated GI, and we're realizing our GI and our immune system and pain are very much correlated. And when I'd have to make big speeches, and I always say this is my TMI speech for my patients and things, but when I'd have to make big speeches or talks at conferences, I was in and out of the restroom all the time. I was like extremely dysregulated because it was a massively stressful thing for me. The lovely thing and the fortunate thing for me is that talk would be done and my system would calm right down. The problem is that talk never ends for people. That stress of to have it, because it's life, it's the financial troubles, it's the loss of relationships, it's the loss of who they are, it's the loss of their role in life and feeling lost of who they're going to be henceforth when they're not the person they were prior to this pain situation. So I think that's one of the big things, is trying to help, because there's so much horrid narratives out there on pain that get people feeling more and more broken, right? There is no shortage of people on YouTube and Instagram and TikTok and all these places that will convince you that there is some faulty structure that is at play here. And if you read that as a patient or you go into, I don't know how you don't come out of that feeling like a more broken, failed human. And I think there's just a lot of hope for people if we can help these topics and help them understand that maybe I don't need to search for the next tissue-based fix. Nothing wrong with having some things that help our tissues along and maybe help them become healthier. But sometimes it's just starting to learn how to control the distress around their experience and start clawing back some things that bring a smile to their face, that bring a laugh, that bring a relationship back in their life, that can start re-regulating systems to not be in such a situation where sensitization and all these processes that we know physiologically, neurobiologically happen. Those topics, I think, from helping clinicians make those connections, but most importantly, helping patients be able to make the connections of their story and their body's behavior. because I think those two have been traditionally put in two different buckets and they're not brought into the same encounter. And I think the most powerful clinical encounters for patients are the ones that can take their story and connect it to their biology. And I think that's a skill we need to continue to develop.
Yeah. Mark, I always remember how we met. I think that there was a conference where I think we all ended up attending over in Boston, over in the States, and where people with, I will say, I'm not lived experience, I'm living experience because I'm not dead. So all people with a living experience of pain. So like myself, Keith, Joe Belton, and we was invited to do workshops, etc., at the International Association of Study of Pain at their congress there in Boston. And we all met there. I think we knew each other vaguely on social media. And Bonnie Thompson from New Zealand, she was there, and I think Keith Carroll, he was there. And it was like a springboard. I don't know what happened from there because out of that, being invited to that congress there and meeting each other, etc., it felt like, well, for me anyway, I felt like I wasn't alone anymore because I always felt I was a bit thinking, I'm whistling in the wind sort of thing. But after meeting Joe, Keith, the two Keiths, Bryony and whatnot, yourself, it was like a turnaround really. And now I think sort of listening to each other, I learned so much from all the other guys. But I think that was a massive influence for us to go off and do stuff like and why? But since then, there hasn't been a similar congress like a conference, and it's what a couple of years ago, or it'll be 4 years ago in February. Myself and Keith was having a chat, and I said, "Well, why don't we get invited to these gigs? Like, why are we there?" And I said to him, "Hey, what do you think? Should we do our own thing? Like, but we're a role model." So what we did, we organised the Pain Supported Self Management conference online, of course, and but what we do is we invite. By the way, you're going to get invited. Not you can't get you in this year or next year in February, but we're definitely going to have you in 2027. But yeah, so keep that clear.
Man.
It will be in February. But so what we do is a role model, because supported self-management, it's all about teamwork. So we have 3 self-managers and 3 healthcare professionals like yourself. And so there's that balance there, and so we're doing the 4th one, I think, on the 21st. I think in North America, it'll be on the 20th, but in Europe and New Zealand, Australia, it'll be the 21st. And we started also now initiating a pain self-management week as well. So like on the 16th, on that Monday, all throughout the week, we're inviting people to share about all matters relating to pain self-management. So we're trying to keep that momentum going, keep it nice and fresh, etc. But to me, it's going back to that other thing, the education bit, where we can educate each other and spot ideas, etc. I love it.
Yeah.
Yeah. Thanks. Okay, nearly near the end now. From Penny from the UK, she says or asked about future of pain care. This one always interests me, because I like to hear about what's everybody like. They love to hear what you're doing, what Joe's doing. Keith has just kicked off something in Canada, isn't he? Action on Pain with his podcast and whatnot, and everybody's been super busy around the planet. But the future of pain care. So, in your experience, what do you see as the biggest challenge in facing pain care today, and how do you envision the future of pain management evolving to better meet the needs of the patients? I'd like to include healthcare professionals in that if I can as well.
Yeah, for the future of pain care, I think where I see it going, and there's a couple things. There's some concerns. I'm all for AI and tech and leveraging it in a way that serves us in the best way possible. I do fear sometimes that furtherly strips the humanity out of the experience when you're trying to have AI interact with the human. I think there's some helpful maybe triage things or different things that maybe can set up a clinician to be able to be more present in a interaction and not buried in their laptop typing in their electronic medical record. So I think there can be helpful ways with that. So I think the future of pain care, there's so much going on in the biomedical space, which I think AI and other models can hopefully help us, better have treatments. Because I don't think we can discourage, because I've sometimes been accused, well, you just want to talk to people. No, I still think there's helpful ways to treat pain, be it medical approaches. If we can help people with fibromyalgia or chronic fatigue or various of these chronic overlapping pain conditions have a better ability to manage pain, and then also still having them connected with somebody who's also on a let's get you back to your life component too. So where it's all working in a synergistic, not like where it gets so disjointed and people are put in their little siloed buckets where nobody's putting the story together. So that's where my dream would be, is true health pain care that helps form a story and a narrative for a patient where they can understand how their unique journey has impacted their unique pain, and how they can have strategies to impact their unique story to start getting back to the life they want to live. So I think some of the advances in technology are great. I do think AI that allows us to be more present in a conversation and an interaction with person can be something very helpful. Again, I just fear sometimes of us getting less human by getting too enamored with technology. And you're talking to somebody who, my wife has declared me a technology junkie, so I'm all for it. But I think, again, we have to put it in perspective to make sure we don't lose the humanity of what we're doing. And I think that, to me, those are the advances I think we can make, is how do we better understand how the mind body influences each other, because too often in healthcare we've put those two in two separate buckets. You're going to talk to somebody about what's going on in your head and somebody who's going to go on talk to you about what's going on in your body. They're one and the same. You can't cordon those two off, because what goes on in your head influences your biology. When that head is in a haunted house, it trucks out a lot of distress, stress, and different things. So I think we need to have a future of pain care that helps patients better have information to connect their unique story to their unique biology and how their body's expressing pain, and then have some medical advances that can help support that as well. I'm not saying, again, medicine doesn't have its place. It's just often patients are so stuck in the, I need to find the next tissue or medication or next procedure that's going to fix it. And nobody's helping them understand their life around their pain. That's probably driving the situation more than their x-ray or their MRI or whatever tissue-based variable that, and again, they can have importance. I'm not saying we strip tissues out of the equation, but when people have been chasing tissue-based fixes for sometimes decades, and life still isn't getting better for them, I think we need to take pause, both as patients and as clinicians. Like, we need to do something different. And I think that difference is helping connect them to their story and how they can rewrite their story and take control of that driver's wheel to start charting a different path with it. And it doesn't have to just be a healthcare system that isn't listening, that's failing in more and more procedures to fix their pain, where they can start getting the wheel and starting to fix themselves, I guess you would say.
Yeah, I agree, Mark. It's getting, it's about balance again, isn't it, with using the technology. I started getting into a little bit technical side of it a few years ago with VR, virtual reality. So there's like, I started, because how I looked at it was trying, how do we engage patients? How do we engage healthcare professionals? And I started, funny enough, I found a link from a Japanese doctor who used this virtual reality platform. And so I built like rooms there, like where there was lots of posts. I was able to post things on the walls, etc., and so people could go onto VR. What I liked about that program, I've still got it now. That platform is because you don't need a. I've got the headset and everything, but you can use your phone or your laptop, is what we got now, except for your computer or whatnot. And so people can drop in and out. I'll drop in from time to time and see what's going on. I'll see people in there. They're just chatting away with each other. So, well, that looks interesting, blah, blah, blah. And then I've got interest. I've been working with Teesside University from the Northeast, and they found some money to make me into an A person. You know, I had to sit in a room for 2 days asking questions about the pain toolkit, self-management, and my life, etc. Like, and so that was quite interesting. I had to sit in the same position for 2 days, so there's anything. And so, but it's about balance, and you can't beat that human contact, like whether it's in face to face or even just like this, really. But it's about balance, isn't it? Especially because if there's another COVID thing, like everybody's got to shift back to this again. Like, but I think I'm always wary of when technology favours those that live in rural areas over there in the States. It's a massive area, like, and not everybody can get to a clinic or a practice if they're living out in countryside, etc. But it's about balance, and how do we do that? That's the interesting bit. Like, but are you with technology? So how can I grab someone's attention, really, especially the younger people? Because it's no good giving them a booklet like a pain toolkit booklet. Because where I live in for account, if I've given them a booklet, they'll roll it up and try and smoke it.
Yeah.
So that is pretty pointless. So it's how do we engage people, especially the younger people? Like, how are they using technology to get their information? But it's all about balance.
Yes,
Okay, listen,
absolutely.
we've done all the. I'm going to go on to a bit of fun stuff, really. Just there's a couple of questions, two more questions, and then I'll let you get on back to work or get to work. So, a superhero for pain relief. So, if you could have any superpower to help your patients with pain management, what would it be, and how would you use it?
I would give people the ability to see their own potential, to impact their own pain experience, I would be able to help people be able to look inward, because I think too often people have surrendered the steering wheel of, not by choice, but because healthcare kind of takes it from them. And I think I would help patients in pain understand that they have the capacity to drive their experience in a much better situation if they give themselves some grace, some self-compassion, and some patience to start taking control and get guidance and be able to be confident to take the steering wheel of their experience, even though healthcare will make them feel like and it will feel probably scary, unsure, uncertain, because it is a journey where it's not a clear cut. We don't have Google Maps that's going to navigate you perfectly always to the destination. It can be met with all sorts of detours and things, but I do think within our patients lies the capacity to live well again. And I think healthcare, we need to get out of the way in a lot of cases and help patients understand that superpower lies within them to get that. Now, there might be some supportive things we can do as healthcare people to help them better steer, better clear the windshield, better get shocks on the car and all those things that help support their car's journey on the self-management. But to me, that's been the number one transformational thing I've seen with people, is when they no longer feel they're beholden to a pain physician or a physio or a chiropractor or a massage therapist. And none of these folks they can sit in the back seat. That's nothing wrong with it, but they shouldn't be driving. The patient should be driving. And I think the more we can help patients recognize that they have the capacity to, even though it's going to feel scary, it's going to feel uncertain, that within them, they have the way to drive. They've driven a bike before. It's going to feel scary. It's like they haven't ridden a bike in decades, but the ability to live well is within us all. It's just sometimes it gets very much limited and restricted by a very distressing, massively life-altering experience. But if we can help them start reclaiming the steering wheel, I think we can make people, I think that would take healthcare a heck of a lot further when it comes to pain.
I've just come across a lovely lady over in the west side of the county. I live in Essex in the UK, and we had a meeting the other day. She's an illustrator. I'm going to ask her if she can do an illustration of you with your superpower.
Nice. I love it. Perfect.
Pulling paper or something like that, and I don't know. Hey, listen, the last question. So, listen, I've organised a dinner party and of people like ourselves that work in the pain management field, etc. So, who would be your three? You had the opportunity to invite three guests. Mm-hmm. Who would those guests be? Still living, or they've unsadly passed on?
That's a great question. It's probably been interesting, and this may change day to day depending on what I'm reading and what I'm consuming in my own life. But as I think about it now, a person I would love to have the chance to sit down and have dinner or a coffee with would be Lewis Gifford. He's no longer with us, unfortunately, but such a transformational figure as far as physio that was probably on the leading edge of us really questioning how we look at pain and why a traditional physiotherapy approach, and this translates beyond just physiotherapy, chiropractic, osteopathic, all these different professions, could learn from him. And he just shares I saw myself in his journey, because there's a lot of parallels in what he went through and what I went through in my career that felt like it resonated. And he just was such a forward thinker. And he was talking about things decades ago that were just still doing much better. I think hopefully he would be happy to see where we're moving, but still not enough. So he'd be definitely one of the people. Strangely, one of my big things I've pursued is, as we've talked a little bit about in this interview already, is how do we get this message to people in a way that resonates and gets them to take action and make a change in how they look at pain. So somebody who I think is probably one of the leaders in doing that in marketing is Gary Vaynerchuk. He's a pretty bombastic, doesn't always have the best language, but truly I think is out there to help humans in his own way, as far as to help them spread a message and be able to put positivity in the world. I think we owe it as healthcare people who are trying to make the change of patients trying to consider something differently, to learn how to message and put themselves out there and help improve the human condition through social media content and marketing messages that meet humans where they are right now. And that is on TikTok and on Instagram and on YouTube. So I do think I'd love to just have a day with him to say, and have him just go through my messaging and here's how you start reaching these people to the best of your ability. Because I think there's a degree that we're not taught that as healthcare people. So how do you market the message that competes with all the garbage out there around that has people disabled and believing they're broken? So he'd be one. last person I'd probably have, I've really had interest in Buddhist philosophy. I think that just a lot of what we look at with self-management and acceptance commitment, and a lot of psychological principles come out of that a little bit. I think obviously he's had traditions of generations of wisdom in the Buddhist mindset passed out down to him. So, and he has quotes that just always resonate with me as far as like how man's endless pursuit of finances to the peril of his health is something that's a mystery that we still fight in modern society. So he'd be just an amazing person to sit down and talk to. I'd love to have those folks at a dinner table. It'd be an interesting dynamic for sure with those three, but I think a great dinner party nonetheless.
Yeah, I'd like to check him out as well.
Yeah.
I started following watched a video years ago by a Tibetan monk, and he talks about the monkey mind. He said we're always overthinking, and it gets very busy. He said you work with the monkey mind, like you have to give it something to do, and you can't give it a banana, so you've got to give it something to do. So just breathe in, breathe out, just concentrate, breathing in, breathing out. And to me, like you, I'm really into all that sort of stuff as well.
Absolutely.
Well, listen, Mark, it's been fantastic flipping the tables on you, and I'll tell you, I can't wait to see the video, etc. And thanks very much for giving up your time, and it's really appreciated. And we're definitely going to get you in February 27th, me and myself and Keith. And so thanks everybody for watching. As I said, do you want to give your channel a couple of plugs, Mark?
Sure. You can find me on Instagram and X and all these at Kargela DPT. I'll put a link in the show notes if you're watching this on my channel, and I'll send it to Pete. Modern Pain Podcast is the podcast where we try to start helping this type of content and patient-facing things and clinician-facing things where, again, we're all on a shared expertise journey together. That's where I try to make sure we're having some good conversations that keep that stuff front and center. So that would be where to hang out and hear more from me. I'd love message me on social media. I love hearing people who are trying to navigate these struggles themselves. And if I can help in any way, I'm happy to do so.
Again, Mark, thanks very much. Have a nice day, and listen, stay safe, look after yourself. Thank you for all you do to support the pain self-management message, and we'll see you again soon. Take care. Have a great day, Mark. Ciao.
You too, Pete. Great talking.